Greetings and a warm welcome to everyone in attendance. I'm Rimpa, the assigned moderator from Clanet, and I extend my cordial greetings to all the delegates from across the country. We sincerely appreciate all the doctors who have taken the time to attend the session with us today. Allow me a moment to introduce our platform Clanet. It is India's most trusted live digital CME platform, which allows doctors to create their own medical content. Now, it is my proud privilege to welcome our keynote speaker for today, Dr. Naveen Kumar Kuswaha, sir. Sir holds a degree MBBS, MS, General Surgery, and DRNB, Surgical Oncology, qualified surgeon, currently serving as a consultant in surgical oncology at Rajiv Gandhi Cancer Institute and Research Center. He is actively involved in comprehensive cancer care with a strong focus on evidence based surgical management, multidisciplinary collaboration, and patient centered outcomes. Thus, we are honored to have such a renowned expert with us today to share his insight on the topic patient selection and perioperative evaluation for CRS and HIPEC for peritoneal metastasis. So, now without further any delay, sir, over to you. Thank you.
Hello, good evening. Good evening, everybody. So the topic on which I'll be giving the talk is patient selection and pre-operative evaluation for CRS and HIPEC for peritoneal mets patient. Myself, Dr. Naveen Kumar Kushwaha, I'm a consultant in surgical oncology at Rajiv Gandhi Cancer Institute. So, firstly, the disclosures. There are no conflicts of interest related to these presentations. There's no financial relationship, industry funding, or any other commercial associations to disclose. Now, the most important thing to understand is that since the starting of CRS and HIPAC in the 1990s and till today, so when the first it was developed, it was for appendiceal origin colonic CAs with peritoneal mets. And since then, the number of indications for which CRS HIPAC is being done has significantly increased. Presently, it is being done for pseudomyxoma peritoni, peritoneal mesothelioma, primary colon and rectal cancers with peritoneal seedling, which is M1C, colorectal carcinoma with peritoneal cytology positive, ovarian, and for primary gastric CAs with peritoneal mets. So, as you can understand that the number of malignancies for which CRS and HIPAC is being done have significantly increased. The indications have increased. So, why patient selection matters? The most important thing to understand is that, as you can see in this table which I have presented in this slide, that all the histologies, if I discuss the pancreatic adenocarcinoma, the gastric, and the associated estimated median survival time which is associated with them, you can clearly see that the once a patient develops peritoneal mets, then the median survival is very, very low. And for a low grade malignancy like low grade appendiceal neoplasm, it is almost to the tune of 5 years or so, but otherwise it is very less than around in the range of 6 to 12 months or so. So the only treatment modality which we can provide to the patient is a cytoreductive surgery with HIPAC. Now, cytoreductive surgery with HIPAC can confer a meaningful survival benefit only when it is a optimal cytoreduction. That is, there is a CC0 or CC1 is achieved. So the patient selection is very, very important. Again, the surgery itself is a morbid surgery. So we have to take all these things into account and then we accordingly plan a particular patient. Now, the incidence of non-therapeutic laparotomies usually exceeds to the rate of 20 to 25% for patients who have been taken for CRS and HIPAC just because of poor patient selection. Now, the issue with this, now the reference article is a Ferron M. et al. Now, implication is this, that once, see, the patients which are being taken for this are basically undergoing some form of treatment. They are already metastatic. So if we give them, offer them this treatment, then their systemic chemotherapy treatment is discontinued for some time till the time the patient recovers from this particular surgery. Also, these procedures themselves are morbid, so there is associated complications. The morbidity is in the range of 30% roughly. So these procedures themselves can also be harmful to the patient. So we have to select the patients in a very critical manner. Now, I'll just give you a reference of a transatlantic pancreatic surgery consortium, in which they found out that patients with locally advanced pancreatic cancer, the post-operative mortality in patients who underwent a non-therapeutic laparotomy was very much similar to those who underwent a major resection procedure. So, though this is not related entirely to this, but you can understand what is the point of doing a non-therapeutic laparotomy. How bad can this be for the patient if we do not select the patients in a judicious and critical manner? So once we select the patient properly by following a protocol, so what benefits do we achieve? First is that the number of negative laparotomies are reduced. Second is that the preoperative assessment of the extent of peritoneal carcinomas guides regarding the feasibility. So if we plan, then only we can execute. So we can achieve optimal cytoreduction, and this likely translates into long-term benefits. Protocolized preoperative assessment. This allows for accurate stratification of the extent of disease. So once the data which we have, all the institutions are following the same protocol, then we can compare one institution's data to the other. Now, what are the core determinants which we have to consider while selecting the patient? The number one is histopathology, including the lymph node status. Second is radiological disease distribution, in which we do a preoperative CT scan of the thorax, abdomen, and pelvis. Third is assessment of the peritoneal cancer index, including the response to neoadjuvant chemotherapy, and there is something called as a prior surgical score, or the PSS. Now, the very first thing, histopathology, including the lymph node status. Now, these are two Kaplan-Meier curves which show that once a patient histopathology is a higher grade or a more severe histology, for example, in appendiceal neoplasm, if it is a benign adenomyosinosis versus it's a adenocarcinoma. So in the red line, you can see how dip is the survival. Similarly, lymph node being not involved versus involved. Again, there is a dip in the survival curves. So these two factors are basically prognosticating. One can guide the patient that if for a particular histopathology we do this particular procedure, despite that the survival is influenced, how can be explained based on these two factors. Now, signet cell morphology is a very common, is an entity which we encounter. Now, this basically reflects an aggressive tumor biology. So there is, with this histology, there is diffuse peritoneal dissemination. So the very probability of achieving optimal cytoreduction is reduced. And this is associated with poor outcomes after CRS and HIPEC. A majority of the cases, it is suggested to be a relative contraindication for doing a CRS HIPEC. So as mentioned in these two references which I have provided. So the net inference is that poor prognosis, signet ring, high-grade tumors, lymph node positivity, while favorable are these like pseudopexuma peritoni, peritoneal mesothelioma. So these, again, the only point of benefit is prognostic implication as to how to guide the patient regarding his outcomes of the treatment. Now, there is something called as a PCI, which is a peritoneal cancer index, in which the entire abdomen is basically divided into 9 regions, and the bowel along is divided into another few regions. So total there are 13, and based on the marking there is a total score of 39, and higher the score, more is the peritoneal disease, and this has a poor prognostic implication. Now, how do we plan a patient prior to taking him up for surgery? So we do a imaging to assess the extent of the disease. So a contrast enhanced CT of the thorax, abdomen, pelvis is the standard investigation which we do for most of the patients to check how much is the disease intra-abdominal and if there is any extra abdominal disease or not. But the thing is that the sensitivity of the CT for peritoneal tumors less than is very, very low. It has been found to be only 25 to 50% compared to 85 to 95% for the larger tumor deposits. Now, these two graphs basically clearly indicate that for a 0.5 centimeter disease, the sensitivity is just 28% in this particular study by Jacket et al. And in this, it is just 11% in this study by Ko et al. So when the lesion size decreases, the sensitivity of CT to assess or help us predict the PCI is very, very low. So the pre-operative CT PCI basically underestimates the extent of carcinomatosis because we are not able to tell correctly whether there is a less than 0.5 centimeter disease or not. And this underestimation is to the tune of 33%. So, do we have some other investigation to facilitate our thing? So, it has been found out that PET CT, which is very routinely being done for most of the malignancies, this adds some extra information regarding the extra abdominal disease. But as far as the peritoneal mets are concerned, the intra-abdominal, it does not add to any good information. So, when we do a CT, though we are underestimating the extent of the peritoneal disease, but there are certain concerning radiological features. What are concerning radiological features? These are the features presence of which basically decide how optimally we can cytoreduce the patient. So these are the few features like bowel obstruction or partial obstruction at more than one site, non-mucinous ascites, mesenteric drawn together, mesenteric paraortic lymphadenopathy, porta involvement, hydroureter, tumor more than 5 centimeter in lesser omentum, more than 5 centimeter in jejunal region, CTPCI more than 20, and so on. Now, these are the references also which basically suggest for these concerns. Now, what is the implication of knowing this? So based on the three studies which I mentioned, Rivard, Jacket, and Yan et al., they said that presence of a single adverse radiological feature was associated with a reduced but still possible likelihood of complete cytoreduction. Whereas if there are two or more concerning radiological features, then they predicted that adequate cytoreduction was unlikely. So based on the CT report which we do, if we find two or more of these features, then definitely the chances of us achieving cytoreduction are very less. Now, two distinct radiological criteria which have been found to have high likelihood to complete cytoreduction and prevents patients who are unlikely to benefit. The most important ones are segmental obstruction of the small bowel and presence of tumor nodules more than 5 centimeter on the small bowel, mesentery or serosal surfaces. Now, CT also has this tendency based on as you can see that small bowel involvement is a very important criteria. So there is a CT classification of class 0, 1, 2, 3 based on the associated ascites, what is the condition of the mesenteric vessels. So which class will benefit is as you can see in the last part of the table where there is a disease implication. A class 0 can undergo a complete cytoreduction. Class 1 is also favorable. Class 2, it is possible but may be challenging. Class 3 is advanced disease and there is very low likelihood of achieving complete cytoreduction. So this was the thing. So though underestimating, but still there are features on CT which guide us. Now, as most of the patients of peritoneal carcinomatosis which we deal with are generally undergoing some form of neoadjuvant chemo, majority of them. So there has to be a way for us to select patients post neoadjuvant chemotherapy who will actually be best candidates for cytoreduction and HIPEC. So the response to neoadjuvant chemo, I'll just give you an example of this. This was a 60-year-old woman with a signature gastric adenosis of the stomach and with gastric outlet obstruction. So she underwent CRS with HIPEC after neoadjuvant chemotherapy. Now just see, preoperative PCI post chemo was 0. Imaging showed complete response. But when we did the surgery, PCI at exploration was 18 and PCI post resection was 7. So clearly, CT PCI does underestimate the thing, particularly for a signet ring kind of histology, it very much underestimates. Now, even the PCI at exploration was comparatively quite high. It was in the range of 18, though it was a doable thing, but still the PCI was higher. So other than the radiology, we need few other factors, other things to incorporate adjunctive modalities such as diagnostic laparoscopy and serum tumor marker evaluation to improve our preoperative disease stratification. So first is diagnostic laparoscopy. So diagnostic laparoscopy for preoperative selection So this was a systemic review and meta-analysis which was done in 2024, and the finding is that if diagnostic laparoscopy is done, then the pool sensitivity was somewhere around 98% and specificity was 83%. So it had a very good diagnostic accuracy, though it is not part of the guidelines at present, but it has to be implemented to see the extent of disease and then proceed ahead with the procedure. Now, tumor markers. Now, tumor markers, there was this study which was done by Levi et al., which demonstrated that preoperatively, if the tumor markers like CEA, CA99, CA125 are elevated, then these are strongly associated with peritoneal disease burden, and the likelihood of incomplete cytoreduction are more, and there is inferior overall and disease-free survival. So definitely tumor markers have a role to play. But can these changing levels of tumor markers can be utilized? So yes, there are few studies which have been done recently in 2025 in which they found out that if post surgery after the peritoneal lavage, if we evaluate the peritoneal fluid CEA, CA19 levels and there is a dip, then these basically are a very good representative of how optimal our cytoreduction was. Now, there's something called as a prior surgical score. As we know that most of the patients with peritoneal carcinomatosis, they generally undergo repeated surgical procedures. So this score was just to address that situation where a patient has undergone repeat surgeries. So based on the extent of surgery which was done previously, for example, a PSS 0 means biopsy only was done, PSS 1 is like laparotomy and one region was addressed, 2 was 2 to 5 regions, and 3 was laparotomy with more than 5 regions. So you can see that if previously a more extensive kind of surgery was done, say PSS 2 or 3, then the survival is comparatively lower. Basically, more the surgery, there will be more the additions, and it has been found out in studies that cancer cells get entrapped in the pelvis. If suppose a rectal procedure or being is done, or there is some gastric CA, metastatic gastric CA, then in the left upper quadrant, because of which we are not able to do a complete cytoreduction. This is because of tumor cell entrapment. So again, this score also guides us in planning a patient for a CRS HIPEC. Other than planning, there are few nomograms which basically give us a prognostic idea as to when we do the surgery, how will be the outcome at a later point. For example, there is a colorectal metastasis peritoneal MET score, COREP score, there is peritoneal severity disease, peritoneal surface disease severity score, and there is prognostic scores. So all these scores, they basically involve the symptoms, how much was the PCI, how was the final histopathology, or based on blood investigations, we can guide our patient regarding what will be the outcome of the surgery. Now, so we, based on this disease status, we've already understood that there are a few things which we need to do to select a patient just for the disease point of view. Now, other factors like a preoperative evaluation for any other major surgical procedure, the same preoperative evaluation model is followed for this particular surgery also. So we need to assess the performance status of the patient, the neutral status, the comorbidities, organ function, and any prior chemotherapy received. Rehabilitation is very important. Nutritional optimization. Albumin, a low albumin has been found to be associated with higher morbidity. So a patient, if very albumin is low, then he might require TPN. He will require TPN in his preoperative period. Similarly, smoking cessation, any medications which need to be adjusted, physical conditioning, patient counseling, all these are very important while planning this patient. So the journal workup of a patient for CRS HIPEC follows the same protocol. We evaluate all these factors along with their cardiac, the renal, and respiratory if needed, based on any anesthesia risk assessment. So an ideal candidate for CRS and HIPEC will be one with a limited peritoneal disease, low to moderate PCI. Low to moderate PCI is generally a PCI less than a 17 to 18. In some cases, it has been written as 20. And there is a complete cytoreduction which is available, achievable. There is a favorable tumor biology and the patient has a good performance status. Now, so what is the future of patient selection? So now things are moving toward more of a biomarker driven selection. as I have told you that a lot of tumor markers are being utilized, peritoneal fluid tumor markers are being utilized. There are uh, fresh imagings like diffusion weighted MRIs to better assess the peritoneal mets for better assessment of PCI. There are radiomics. Radiomics are basically deep learning or machine learning models which, based on the serial imaging of the patient, can better guide us what will be the actual PCI of the patient so that we can plan the surgery accordingly, thereby reducing the number of non-therapeutic laparotomies. So this is how a progress is being made. So hopefully I've tried to explain as much as we can do for the patient to select an ideal patient for CRS with the IPAC. And thank you. And now any questions if there are?
So, am I audible to you?
Yes, yes, please.
Yeah. So, thank you so much, sir, for the wonderful deliberation. The session was really informative. And yes, we have received few questions from the participant delegates. So, may I have your permission to share it?
Ah, please, please.
Yeah. So, you need to stop share your screen, sir.
Okay.